Good evening, ladies and gentlemen. Thank you for joining our webinar on protecting the brain in the COVID and post-COVID era. My name is Basil Mata. I'm a consultant in anesthesia and critical care at Cambridge University Hospital and a senior medical director for Masimo International. I'd like to thank the Canadian Critical Care Forum for hosting this webinar, Dr. Denault, my co-speaker, for his time and effort in joining us, all of you for attending this webinar, and Masimo for sponsoring it. We will run this webinar for about 50 minutes or so, at the end of which you'll have an opportunity to ask questions. In fact, you can ask questions throughout the webinar by using the chat line. Thank you once again. I hope you enjoy it. Hello. Welcome to Monitoring the Brain in COVID-19 Patients. My name is Basil Mata. I'm one of the consultants in anesthesia and critical care at Addenbrooke's Hospital at the University of Cambridge. I'm also a part-time senior medical director for Masimo International. For the last 20 years, I've cared for patients who suffered a brain injury. And as I get older, I begin to worry about my own brain, and I intend to spend the next 20 years preventing healthy brains from being injured, and hopefully one of those would be my brain. Now, coronavirus has hit us pretty hard, and we assumed it was going to be just another respiratory tract infection. But actually, is it a respiratory tract infection? Coronaviruses, for those who don't know, are a large family of viruses that cause illnesses, wide-ranging illnesses, from common cold to severe diseases such as the Middle East respiratory syndrome, first discovered in Saudi Arabia in 2012, and the severe acute respiratory syndrome, SARS, which was in 2003 in South China. Now, COVID-19 is a new strain, not previously identified in humans, first noted in December 2019 in Wuhan, in China, and the infection has now spread for over 200 countries around the world, and the most severely hit has turned out to be the United States, with over 2.5 million people infected, Brazil at about 1.3 million, Russia at just over 500,000, and the United Kingdom at 350,000. Canada has been pretty good at this, and they've escaped with about 100,000 infections and about 8,500 deaths. Now, COVID-19 is a virus that can really spread very, very rapidly and can be fatal. To date, over 10 million people have been infected worldwide, with over 500,000 deaths. And the case fatality rate varies between 1% to over 10% in certain populations. And most patients experience mild symptoms. Some are totally asymptomatic and recover without any medical intervention whatsoever. Sadly, for those who end up in intensive care, the mortality is pretty high, reaching 40 to 50% in finished episodes. It's slightly improving now as we're getting more able to deal with this disease, but it's been a pretty high mortality. The range is anything from under 20% for those under the age of 40 to over 70% in those over the age of 70. Interestingly enough, what we're seeing with this virus is a high incidence of thromboembolism, around 30%, myocarditis, and renal dysfunction. The morbidity and mortality increases with age and comorbidities. And most organs supported, obviously, are the respiratory system, the cardiovascular system, renal support in 20% of patients, and also neurologic support, ranging anything between 5 and 8% of patients. Now, the common signs of infection as a disease of oxygenation, it used to be said that it's a fever and a persistent cough. But since we are more adept with how the virus is behaving, we know now that shortness of breath, wheeze, hoarseness, non-persistent cough, even in new cough, nasal discharge or congestion, and even the loss of sense of smell are signs of COVID infection. The most severe cases obviously go on to develop pneumonia and ARDS, and a high percentage end up dying. And as I said, lots of other reported core complications. Now, when we end up seeing COVID-19 patients to critical care physicians and anesthesiologists, it's generally because the patient requires admission to intensive care, and we admit them to intensive care to improve their oxygenation. Now, most of the patients start by having supplemental oxygen while breathing spontaneously, and they may go on to high flow nasal oxygen. They may even try CPAP and NIV, and then eventually, when all of this fails, you end up intubating those patients and mechanically ventilating them. Now, some units like ours chose not to use high flow nasal oxygen and not to use NIV and CPAP in outside negative pressure rooms with full PPE on. Not because they're not beneficial, but because the risk of contaminating our staff and other patients is just simply too high. Now, this is an example of a patient who has got COVID-19, and you bear with me and look at the slide here. The top part is the respiratory rate. The second part is the carbon dioxide, and the last part is the oxygen concentration in the blood, PO2. And you can see that this patient, over a period of days, as they struggle with hypoxia, they begin to breathe faster and faster. And as they breathe faster and faster, they blow off their CO2. And as you all remember the alveolar gas equation, as you blow off your CO2, you compensate for the hypoxia because you increase the concentration of oxygen in your alveoli. And these patients don't seem to be too distressed because hypoxia itself doesn't distress you. It's the high carbon dioxide that does that. And when they get to the end here, where they can no longer breathe any faster, when they're going at 40 breaths per minute, they're tired, they've been doing this for a couple of weeks, they fall off the cliff and they desaturate very, very rapidly. Now, when we admit them to intensive care, this talk is about sedation. And what are we talking about here when we talk about sedation? Why is sedation necessary in ICU patients? Well, a simple thing is that because we intubate them, we want them to tolerate the endotracheal tube. Some severe respiratory failure patients do not synchronize with the ventilators, so by heavily sedating them, we can improve synchrony with ventilators. Patients who have got muscle relaxation to aid their ventilation have a risk of awareness, so we try and sedate them to remove the awareness. There are surgical and surgical conditions like abdominal injuries or chest injuries that require sedation. Obviously, if you're having status epilepticus, or in certain conditions like high intracranial pressure as a result of TBI or subarachnoid hemorrhage. But we have to remember that sedation is not the treatment. Sedation is simply facilitating what we want to treat the patient with. Now, sedation in critical care patients, the conventional sedation paradigms have been changed now. We all appreciate the fact that analgesia is probably the most important part of sedation, and we need to make sure the patients stay as light as possible without being distressed in order to reduce the risk of delirium and postoperative cognitive dysfunction. Reducing the exposure to benzodiazepine has been a mainstay of most critical cares over the past few years. And you can see here on the left-hand side a protocol looking at mechanically ventilated patients, and it's a simple protocol that goes through pain, yes, no, add the analgesics, and go on all the way to reduce the level of sedatives you use, aiming for no delirium if at all possible. Now, most intensive cares use a method of assessing sedation. RASS score is the most probably used score around, the Richmond Agitation Sedation Scale, and you can see that you would like your patients to be between -1 and -2, likely sedated, perhaps drowsy, certainly not anxious or restless, and certainly not unrousable and deeply sedated. So most people would aim for a RASS score of -1, -2, or 0 if possible. Now, the RASS score has been adapted for many, many conditions. This is an example of an adaptation for pediatric patients, and by using the CAM ICU method for assessing sedation, you can see how you can balance your anesthesia, your analgesia, and your pain relief and your sedation to improve the benefit for the patient without increasing the risk of delirium. Most intensive cares should have a protocol. This is the one from Melbourne in Australia. It's a pretty simple protocol. Use a protocol, aim for analgesia first, target a desired sedation score, not just go for whatever is going. Avoid excessive sedation because that increases the risk of delayed extubation, increases the length of stay, and increases mortality. Also, It promotes poor sleep and increases the risk of delirium. And we use the right medication for the right patient. Morphine is a pretty good analgesic and the choice for most patients. Fentanyl for TBI and secondary analgesic like ketamine, dexmedetomidine, paracetamol, non-steroidals, and clonidine should not be forgotten. And again, I re-emphasize the fact that we should use as few benzodiazepines as possible because they are the worst culprits when it comes to delirium in ICU patients. Now, we talk about COVID patients and their description of several phenotypes. There's two main types described, the L type, which is the good compliance type, and the H type, which is the more characteristic of ARDS type patients. And I don't really believe that there is two types. I think it's just a progression of the same disease. So the first bit is when the lungs are got good compliance but poor oxygenation. There's high minute ventilation, lung weight is low as estimated by CT scans, poor response to PEEP, infiltrates are often limited, ground glass in appearance on CT. Many patients do not seem to be very distressed with this, and it may stabilize and they might walk out of hospital without any intervention whatsoever. The other type is the more characteristic type of ARDS. There's extensive consolidation on CT, poor compliance of the lungs. Lungs are very heavy as estimated by CT scans, and there's a pretty good response to PEEP. And you can see this algorithm here. These are the patients that are hypoxemic and still got good compliance. We try non-invasive support on them. You may try CPAP. You may try NIV or high flow. If they don't benefit, then you intubate and use the usual methods of PEEP, sedation, and neuromuscular blockers. And again, those who develop edema in the late stages get late intubated and end up being either, again, prone, high PEEP, or going to ECMO if needed. Now, the two phases require two different things. The first heavy phase, where the patients have got this ARDS type syndrome, they need to be very heavily sedated. They need to be heavily sedated and even sometimes using neuromuscular blockers to paralyze them, to synchronize them with the ventilator. And these are the patients that you cannot use a RAS score on because they're too heavily sedated. That's where we suggest that we need to have some other measure of sedation other than the RAS score. For example, a simplified EEG of some sort or another. Once you get out of this phase, maybe 48, 72 hours later, then you start lightening sedation and stopping paralysis, then we can go back to using the lighter sedation methods and looking at the RAS score as one way of assessing the depth of sedation. But in this group of patients, really an objective measure of sedation, such as processed EEG, is almost mandatory. There's no escaping of that. Now, I don't really mind what we use for depth of sedation. There's a variety of things on the market. There's, you can use suppression ratio, you can use DSA, you can use PSI, you can use BIS, you can use entropy, you can use whatever. Whatever you use, all of those mechanisms, take the raw EEG, use some clever algorithms, and come out with some indicator of either a number or a waveform or a ratio that you can use. And familiarize yourself with the things. I tend to use SedLine because it's the one that's been validated in intensive care. I use it regularly, and it seems to work for us. Now, we know oversedation in ICU is a real problem, but it's even more of a problem in COVID patients. You get this really sick patients who you've intubated with full PPE gear. Risk of extubation is a real serious concern to the staff. These patients may well be turned prone regularly. So inevitably, they'll be oversedated in the ICU. And as I said before, oversedation, longer ICU stay. Cardiac depression means you have to put more inotropic support on, increases mortality. Because if you keep them in ICU longer, there's a physically reduction in number of ICU beds available. And this is a problem we ran in as we accumulated more and more COVID patients. They were getting a lot of sedatives, a lot of inotropes, a lot of drugs. We were running out of those drugs. So we're switching from 1% propofol to 2% propofol and vice versa. And we were also running out of pumps. So if you can rationalize your sedation and get it right, you will save all of these and increase the beds available in ICU to treat other patients. So profound sedation is a problem in mechanically ventilated patients. It's even more of a problem in COVID ARDS patients. This is a study we have submitted for publication looking at oversedation as a risk factor for delirium in COVID and non-COVID patients presenting to critical care with and without ARDS. These are 2 neurocritical care units, one in Northern Italy and one ours in Cambridge. And you can see on the non-COVID side, we had 122 patients. We ended up with 57 who were studied for a variety of reasons, 17 of which had ARDS. And in the COVID group, we had 57 COVID-19 group, and we ended up with 21 patients for a variety of reasons again, of which 21 had ARDS. So most patients were monitored for at least 48 hours. We defined oversedation as a PSI, patient sedation index of less than 30, or suppression ratio more than 2%, greater than 10% of the time. And we looked at 38 patients out of the 78 fulfilled the criteria for oversedation. Almost half were oversedated. And the non-COVID patient were 47%, and in the COVID patients, there were about 53% who had both PSI less than 30 and suppression ratio greater than 2 and more than 10 minutes of the total sedation time. Then we did some more analysis on these things, and you can see here the incidence of delirium. Now, I know delirium has got many factors, including the fact that your brain is infected with COVID-19. But these are the non-COVID patients. The delirium is still around 63–64%, and the COVID patients have delirium of almost all of them had delirium at some stage or another. And if we split them into those who developed ARDS and no ARDS, again, in the ARDS group, almost 1 3/4 more patients developed delirium than the ones in non-ARDS group in the non-COVID group. And in the COVID group, again, delirium was very high compared to the no ARDS group. So you can see that 73%, 3/4 of our patients, spent half of the total sedation time with a PSI less than 30, oversedated. Now, what do we use to monitor depth of sedation? Well, we use Sedline. Sedline is a pretty easy thing to you apply the montage onto the forehead, you connect it, and you get beautiful display of your DSA, your PSI, your waveforms, if you like them, your suppression ratio, and spectral edges. And you know, you don't want to start using Sedline with all its bells and whistles, maybe from day one, if you're not experienced with it. You can start with PSI. Most of the nurses like the display, very reliable. It seems to give you an indication of what's going on. Now, we saw 3 groups of patients that came in that required anesthesia, analgesia, sedation in intensive care. And we wanted to protect the brain. We are a neurocritical care, neurotrauma unit. So the brain is very important to us. So we saw 3 types of patients. Those who came in with COVID-19 without any pre-existing brain injury, who were young and healthy before they got the infection, or some who were young and healthy but had a risk for brain injury, hypertensive, they got cerebral vascular disease, they got cardiac disease. And we had another group of patients who, COVID-19 patients, with pre-existing brain injury, but they didn't come in with the brain injury. They've had previous strokes, they've had tumors, they've had carotid disease before, they've had brain surgery before. And then we had the 3rd group of patients that came in that they were not COVID-19 patients when they came in, but because they were in hospital, they became infected. And those were the traumatic brain injury, the subarachnoid hemorrhages and the strokes. So we had these 3 groups of patients who were all at risk of brain injury. We wanted to protect them. Now, interesting enough, we monitor vital organs. We talk about vital organs in anesthesia and critical care. We monitor. These are the 5 vital organs: heart, lungs, liver, kidneys, brain. We certainly monitor the heart to the nth degree. PA catheters, arterial lines, echo, whatever you like, we do. Livers, we do the same. Lungs, we do the same. Kidneys, we do the same. Very rarely do we monitor the brain. We really don't monitor the brain at all, despite the fact that most of our patients are having sedatives and drugs and techniques that work on the brain. You know, less than 5–10% of patients worldwide have their brains monitored if they're not injured, if they haven't got brain injury. And when we tend to monitor the easy things, the pressure or the flow, but we don't monitor function. And when we monitor function, we tend to use it as a measure of depth of anesthesia to try and save cost rather than look at the benefit and value in protecting this brain from getting injured. And we very rarely monitor oxygenation and metabolism. And it seems strange to me that we continue to focus the least on what is arguably the most important organ where anesthetic drugs work and is the most difficult to heal or replace if injured. I just want you to think about this for a minute. The most difficult organ to heal or replace if injured, and where most of our drugs work, yet we do very little monitoring of that organ. What causes brain injury? Well, whatever the reason for brain injury, it almost ends up being the difference between the requirements of oxygen metabolites in the brain and the oxygen delivery. So anything that alters perfusion, blood flow, perfusion pressure, vasospasm, emboli, anything that alters oxygen delivery, oxygenation, anemia, diffusion, anything that increases metabolism beyond what the oxygen delivery can cope with, such as pyrexia and seizures. And obviously, we've got the direct effects of inflammation and metabolic drugs, such as anesthetic drugs. These all cause injury to the brain. And the brain is very clever. You have, flow metabolism is very tightly matched. Metabolism goes up, blood flow goes up with it. When metabolism comes down, blood flow comes down with it. And when you get flow in excess of metabolism, you get hyperemia. And when you get flow not matching up to metabolism, you get ischemia. We try and keep the brain in the middle, if you can, in this here, where the flow and metabolism are matched as much as possible. We know blood is going in through the arterial supply, goes into the brain, washes out through the jugular bulb, and you know that the brain extracts blood from the oxygenated blood and returns some of it about 75 or 70% saturated. Now, oxygen delivery depends on several things, and the brain is very good. So oxygen delivery depends on your arterial content, which is the hemoglobin, not just the saturation, but the hemoglobin and the partial pressure of oxygen. So a patient with a hemoglobin of 10 can carry 20% more, 25% more oxygen than a patient with a hemoglobin of 8 for the same saturation. Cardiac output is very important, heart rate and stroke volume. So when your oxygen content drops, you tend to increase your cardiac output to improve oxygen delivery. And the brain here, what happens when the oxygen delivery drops is you extract more and more oxygen until you come to a point where it's a critical CO2 delivery, where you can no longer extract anymore and you become anaerobic metabolism, I suppose, and your lactate will start going. This is how the body behaves, and the brain is no different. Once you begin to extract as much as possible, once you get to a point where you can no longer extract anymore, you begin to desaturate, and the brain is at risk of critical ischemia. Now, cerebral oximetry, as I said, we do brain injuries all the time, so we dab hand and monitoring oxygenation. You can put jugular bulb catheters in. You can put PO2 probes, Clark-type electrodes in the brain. We drill a hole, ICP monitor, microdialysis, and PO2 probe, and we monitor them routinely, looking at oxygenation, looking at autoregulation throughout the day. And we can use the near-infrared spectroscopy, which is the cerebral oximetry provided by Masimo and several other companies such as Invoice. Now, realistically speaking, you're not going to be using a PO2 probe or jugular bulb catheters outside your intensive care. That's just not going to happen. You're not going to put it in somebody who's having a hip replacement, with shoulder surgery, or coming in for liver transplant. So what's left? Well, you're left with really a non-invasive measure, which is the near-infrared spectroscopy. And the principles are very simple. Light is shown, and some of the light waves are 4 wavelengths, 6 wavelengths, 2 wavelengths, 5 wavelengths. People have tried everything. And the light is shown, as it shines through, it scatters off the tissues, and it forms an arc. There's a shallow detector that detects the areas that are shallow, and then the deep detector that goes through the substance of the brain and gives you an indication. And then through some clever mathematics and physics, you can get a saturation reading, which is displayed here. Now, it's always difficult to see whether there's some extracranial contamination. Of course there is. Whether it's reflecting the substance of the tissue entirely. Of course it isn't. But generally speaking, what you're measuring underneath the sensor is the balance between oxygen delivery and oxygen consumption in that piece of tissue. So the oxygen is delivered and the oxygen is consumed, and what's left behind is measured. We assume that about 70% of that is venous and 30% of that is arterial. You can change that ratio to 25-70. So that's what the signal tells you. Underneath that sensor, you will get a rough saturation, most likely equating to a jugular bulb saturation. At least that's what's been calibrated against in most sensors. Now, the idea that it's use it bilaterally is great, because then you can see hemispheric variations, you can see side-to-side variations, as Andre Denault's going to talk about in cardiac surgery. You can see the differences if you're affecting perfusion to one hemisphere versus the other. And this is the display you get from the Masimo O3, and there's a few parameters that have been added recently, which I will talk about. This is the saturation, this is the HHBI, an index representing the deoxygenated hemoglobin changes, the HbO2, which is the oxygenated hemoglobin, the saturation, the arterial saturation difference, the area under the curve, and the change from baseline. Now, I don't want to talk about oxygenation for a long time, but every single place you look, cardiac surgery, orthopedic surgery, cardiac arrest, intensive care stay, those patients who have episodes of desaturation below 60%, in cardiac surgery it's more than 15% from baseline, tend to have more chance of developing either delirium or postoperative cognitive dysfunction. That does not mean everyone that desaturates is going to develop delirium, or everyone that desaturates is going to develop postoperative cognitive dysfunction, but the risk increases. And that's something we have to keep in mind. Now, what does the RSO2 and how is it calculated? Well, the RSO2, as I said, is a measure of the oxygen saturation in that tissue underneath those octodes. 70% venous, 30% arterial. It's made up of the change of oxygenated hemoglobin, which reflects the changes in the oxygen hemoglobin used for this calculation. The delta HHBI reflects the change in deoxygenated hemoglobin as a component of RSO2 calculation. And the delta CHB reflects a change in the sum of both the oxygenated and deoxygenated hemoglobin when you calculate the oxygen saturation. This is an example of the response of those three parameters and the RSO2 to hypoxia. There's a patient a volunteer that gets to breathe nitrogen and desaturates. And you can see as the RSO2 and the volunteer becomes more hypoxic, not much happens to the arterial content because that's still being delivered. But what happens is the brain begins to vasodilate in response to hypoxia. And so the brain blood volume increases. So there is more venous change and more total blood inside the brain. So most of the signal desaturation is because the venous component of that signal is increased, okay? Whereas the arterial side is still staying the same. And when you stop desaturating them, the signal goes back up to normal, venous drainage improves, the brain stops vasodilating and goes back to normal, and you can see the percentage of oxygenation recovery. This is a patient who's having cardiac surgery. You can see the RSO2 here, RSO2. As you lift the legs, you can see that venous return improves, and the signal improves. Both the total hemoglobin goes up, the oxygenated hemoglobin goes up, and the deoxygenated hemoglobin goes up. And all three indices expand and go up in response to improved cardiac output. This is a patient who has got a venous congestion. We do a lot of these patients who've got benign intracranial hypertension and have got difficulty draining their venous circulation. You can see here that this patient has got venous outflow obstruction. And when we put a balloon and dilate it, the flow is improved. And you can see what happens to the RSO2 signal. The RSO2 signal increases from about 68% to 73%. Now, this is not increasing because the patient's oxygen delivery is improved. This is increasing because the venous congestion has been resolved. And so, unfortunately, when I did this, I did not have the three parameters on. But now I would expect to see a drop in the deoxygenated hemoglobin. So the ratio of oxygenated to deoxygenated hemoglobin would go up and the total hemoglobin would come down. And that would account for the increase in the saturation. So really the three indices, the delta total HBI change in it reflects the change in the total volume. So you can look at the total brain blood volume, both venous and arterial. The change in the deoxygenated hemoglobin reflects the change in the venous component of the blood volume. So you can look at the brain blood volume changes. For example, when it increases during hypoxia, venous obstruction, venous congestion is often seen post-cardiac surgery and liver transplantation. And the oxygen component, the change in the oxygen hemoglobin, reflects a change in the arterial component of the blood volume. That's changes in blood flow, hyperemia, vasodilatation, higher FiO2, and increase in cell blood flow. So what these three parameters are doing is giving you the ability as a clinician to see what is the relative contribution of all of these things to any change you see in the RSO2. Is the change in the RSO2 because of venous congestion? Is it because of hyperemia? Is it because of venous obstruction? Is it because of increased metabolism? And that is all very important because you can piece that and tailor-make your treatment based on the cause of the reduction. We always talk about oxygen delivery, and that's been the thing about COVID. We talked about oxygen delivery, but we often forget that if you cannot increase oxygen delivery, you must reduce oxygen demand. So a lot of patients, a lot of volunteers, a lot of people who developed COVID and went home to self-isolate, they decided that, well, I'm self-isolating, I will clear the attic, I will dig the garden. Wrong, that's not the thing to do. You have a viremia and you can't deliver enough oxygen. You need to rest, put your feet up. The guys in New York used Radius PPG and Masimo safety net to monitor patients at home. And what they were doing was looking at their saturations. And as the patients began to desaturate, they told them to rest, put the feet up, or maybe even turn prone. So you can actually reduce oxygen consumption and improve your oxygen reserves, if you like. But if you can't improve oxygen delivery and the patient is sedated and ventilated, you can optimize sedation. You can have temperature control. You can prevent seizures. And by using SedLine and O3, you can really optimize oxygen consumption. You can prevent oversedation. You can use muscle relaxants to facilitate ventilation, if you like. You can conserve drugs. You can reduce myocardial depression and the use of inotropes. And also, by using a measure of desaturation and brain function, you can look at seizures, you can look at brain desaturation, and hopefully reverse those and prevent injury. And beyond ICU, we know beyond COVID, delirium, post-ICU syndrome, and stroke, that's really important. Now, the world is talking about post-COVID tiredness, post-COVID seizures, post-COVID strokes. We don't want to compound the problem of COVID by giving the patients injuries while they're being sedated and ventilated in ICU. So in conclusion, critically ill patients are really at risk of vital organ dysfunction. Patients undergoing anesthesia or sedation in ICU have brain-associated dysfunction, but the brain is very rarely monitored. Now, there is an available monitors now, non-invasive monitors. We're not talking about drilling holes in people's heads. We're not talking about sticking needles in people's heads. We're talking about putting a sticker on their forehead that costs less than a stapling device that the surgeons use, or less than a disposable pulse oximeter. This can provide really valuable information that can prevent damage and improve outcome in these patients. And I suppose really a question we need to be asking myself is why wouldn't I monitor brain oxygenation and sedation in patients at risk, as opposed to why would I monitor oxygenation and sedation in patients at risk? I really think we must optimize patient care and ensure well-being, brain well-being in this COVID crisis, because I think it would be a real tragedy if patients who've got the risk of 50% risk of dying recover from COVID-19 only to find themselves nursing a brain injury. Thank you very much for listening. Now, the next speaker is going to be Professor André Denol. André is an experienced cardiac anesthesiologist and intensivist. He works at the Heart Institute in Montreal, and he's going to talk about his experience with brain monitoring in patients in this crisis and beyond. André, thank you very much.
Thank you very much, Basil, and thank you for this very interesting and presentation. I'm a professor of anesthesia. I am a critical care and a cardiac anesthesiologist, and I'm also the director of the critical care ultrasound training program at the critical care division of the University of Montreal. Just going to advance. Move to the next slide. Good. So my activities now are mostly at the Heart Institute. I've been working until, in fact, last week at the Centre Hospitalier de l'Université de Montréal, where we took care of COVID and post-COVID patients. I'm supported by the Richard Kaufman Endowment Fund in Anesthesia and Critical Care from the Heart Institute, and these are my disclosures. We have been interested for many years in brain oximetry, and in 2019 we reported an approach and also our experience based on about 1,613 patients. And on the table 1 of this article, we basically describe the multiple etiology or mechanism of brain and somatic desaturation. And the algorithm that we've proposed is relatively simple. In fact, it's an algorithm where ultrasound, whole body ultrasound is integrated. So the first question, when you have a desaturation and there's a not, and it's not necessarily correlated with the patient condition, is always ask yourself if it's not a clinical mismatch. And an example of this, if you have an unstable patient with a radial artery catheter, as you know, in these patients, sometimes the artery, the radial artery might not be reliable. And in those patients, they have normal brain and somatic desaturation. So this is what we call a clinical mismatch. And then the second question you ask yourself, if you're monitoring patients with oximetry, is the desaturation unilateral? And then it's either an arterial or venous problem, or is it bilateral? And if it's bilateral, is it regional? And we'll discuss about regional brain desaturation. But for instance, if you have brain and upper or brain and lower extremity, this is typical of a superior or inferior vena cava syndrome. Or is it global? And I'll show you some example. In 2017, we start using SedLine at our institution. We were completely EEG naive clinicians, and we report in the Canadian Journal of Anesthesia a proposed approach where we combine cerebral oximetry with EEG, and I'll show you part of this algorithm as we go on. And finally, this is a paper which is in press that's written by one of my colleagues, Shaban Ali, who goes over the clinical and technical limitation of cerebral and somatic near-infrared spectroscopy. And as was mentioning Dr. Mata, when you use oximetry, basically you have an emitting probe and you have a detection probe. The final results, which is your regional saturation, it will depend on the proportion of oxyhemoglobin divided by the sum of oxyhemoglobin and deoxyhemoglobin. So when we are now using brain monitor, we kind of integrate those monitors. So the one we've been using for since 2002 is brain oximetry. And since 2017, we've been using SedLine in the operating room and in the intensive care unit. And as was mentioned, when you use SedLine, you can have the raw EEG, you can have the PSI, you can also monitor the spectral edge frequency, which is the average frequency of the brain on the right and on the left, or you can use also the digital spectral array, or the DSA, and I'll show you some example why this is very useful information. And finally, since 2019, now we've been interested in this new capability of the O3 monitor to display the oxyhemoglobin, which is displayed here in red, the deoxyhemoglobin, and finally the total content of hemoglobin, which is in fact sum of these two components. And if you see in this example, this patient has brain desaturation, but you can see easily that the mechanism is a reduction of the oxyhemoglobin, and this would be typical of a patient whose brain perfusion is reduced. Whole body ultrasound is one of the area which we've been promoting, and David Kenty is one of my colleagues from Melbourne, and Dr. Mata was mentioning monitoring vital organs, but now we have the ability not only to monitor but also to examine them, and you can do ultrasound of the heart, the kidney, the brain, the lung, and you'll see how this is important when you combine this with the oximetry, because basically the oximetry or the EEG tell you you have a problem, and the ultrasound tell you, well, that's the problem. And it's really a combination of these two monitors that I think gives you the most information. If you have any brain problem, a simple technique that you can use is optic nerve sheet measurements, and this is a technique we've been using and describing. As was mentioned by Dr. Mata, there's two types of lung injury or two types of manifestations when you have COVID, and we describe those, but also we describe in this paper how you can use lung ultrasound to identify and to also assess the severity of lung injury when you have a COVID-19 patient. And finally, something we've been developing recently, and we've learned from radiologists, is a very simple technique, which is just basically femoral Doppler interrogation, and that can also help you to rule in or rule out, for instance, right ventricular dysfunction with a simple linear probe. So let's talk about the first situation if you have brain desaturation and then your electrical activity is increased. So this is typical of someone who's awakening, who has hyperthermia, or has seizures. So in that situation, you have localized desaturation of your brain only, and the mechanism is most likely not a reduction in your oxyhemoglobin, but an increase in your deoxyhemoglobin. And this is just an example I'd like to share with you. This is a patient who's awakening, and when you see, you can see there's an increase in the PSI, there's an increase in the spectral edge frequency, and you can also see it in the DSA. This is before and this is after. And on the DSA, on the x-axis is time, and on the y-axis is basically the different frequency of the brain on the left side and on the right side. At the same time, this patient had also a brain desaturation. But when you look in more detail about the components of the brain desaturation, you can notice that most of the brain desaturation was from an increase in the deoxyhemoglobin as opposed to the change in the oxyhemoglobin in this patient. When you have seizures, we use SedLine in the ICU, and you can sometimes pick up those. You'll see the high frequency that would appear. And also, as described by other centers and other investigators, this is a patient who has seizures, and he's being treated with benzodiazepine. And you can see that afterwards, this high frequency activity just goes away. We mentioned that the coronavirus was something really that had an impact worldwide. And in fact, the severity of this condition really depends on the viral load. It depends also on the immune reaction, how your white cells react to the coronavirus. It also will be influenced by any comorbidities, bacterial superinfection. But also what we're realizing now, there's a very important genetic component which probably makes people react more than other to this virus. One of the complications that we've seen in the ICU, and especially in COVID and also after patient recovery from COVID, is really a neurological complication. And one of them is agitation and delirium, which is quite common. Well, the use of EEG monitoring has been described for delirium. And in fact, there's several papers showing that if you have delirium, you can have some change, definitive change in your EEG. That's been described in septic encephalopathy, hepatic encephalopathy, been described also in a patient who developed encephalopathy after any cardiac or non-cardiac surgical procedure. And this is just an example of a patient who's delirious, and this is the same patient once they recover. And what you can notice is that in patient with delirium, you have a lower frequency. And if we analyze those frequency, you're going to notice that in these patients, for instance, the delta frequency was much more important than the control patient. And in the second patient, you can also notice that the higher frequency were much lower in patient with delirium compared to no delirium. This, I would say, is a relatively interesting area and something we are exploring. But I would say the most usefulness of this monitor is really in when you end up on ECMO patients. So when you have ECMO, you need heavy sedations. These patients need to be paralyzed. And one of the common complications that we see is oversedation. And this is an example of a patient. If you look just at the EEG, you see the triphasic wave, which is described in patient with encephalopathy. But also, you can see, and you see it again afterwards, but what you can see is what we call burst suppression. So all these black lines are basically the description on the DSA of burst suppression. And when you see this, one of the first question you have to ask yourself, is it because we're giving too much sedation? And as you reduce the sedation, then you can see a reappearance of normal brain activity. And this is just another patient, a different one who has ECMO. And again, you see the burst suppression. And then you can see when you readjust your sedation, you can see it right away on your patient. So to avoid this condition, I think is very important. And as was mentioning Dr. Amata, when you're in a RAS below -3 or -4, you don't have any idea how deep you are without these types of monitor. And you don't need to have burst suppression in those patients who don't have necessarily primary neurological injury. The other usefulness of brain monitoring, and this is something we had, is as these patients, probably ECMO patient, can develop brain hemorrhage, and they can develop also encephalopathy and brain edema. And when you suddenly lose your satellite signal, this is what can happen in these patients, severe brain edema. However, you don't necessarily need to send these patients on a CT scan. You can use ultrasound, and one of the validated technique is just to measure the optic nerve sheath in those patients. And we've described previously that you can monitor the change over time of the optic nerve, as other investigators also shown as a way to monitor intracranial hypertension. When you have brain desaturation and now your EEG is coming down, the next step is to ask yourself, is it something local or is it global? So this is when you may look at your somatic oximetry, and if the somatic oximetry is normal, then you know the problem is in the brain. And in that particular case, then it's a problem of cerebral blood flow. So you'll see a reduction in your oxyhemoglobin in those patients. One of the simplest way to assess this at the bedside is to do transcranial Doppler. And when you do transcranial Doppler, and this is a technology we are using in the cardiac OR, and you can also use it in the ICU, well, there's several information you'll get. You'll know there's 4 possibilities. First, you know, is it a unilateral reduction or is it bilateral? And then the systolic value will be influenced. The systolic velocity will be influenced by your cardiac function, but the diastolic value is also important, because as you increase your intracranial pressure, the diastolic value will come down. But also, as we see in cardiac surgery, if you have significant increase in your venous, if you have venous congestion, the diastolic velocity will also come down in those patients, such as, for instance, after heart transplant, if you have superior vena cava syndrome. If ever the somatic oximetry is abnormal, then you know the problem is not from the brain. And then there's 2 possibilities. Either you're reducing your oxyhemoglobin, or you're increasing the deoxyhemoglobin in those patients. And the 3 most common possibility is that output is reduced, your hemoglobin is reduced, or you have a reduction in your oxygen saturation. So in terms of oxygen saturation, our experience, when you have a desaturation, often what will happen is that you'll see it before on your brain oximetry. Because when your PO2 goes from 400 to 100, you won't pick it up on your pulse oximetry, but initially you'll pick it up in your brain monitor. And then if you don't correct it and you go on to having pulmonary hypertension and RV dysfunction, this is what will happen afterwards. So these are some examples of patients who have a desaturation, systemic desaturation, and I'll just show you how it looks like. So this is a patient, that's his EKG, that's the arterial blood pressure. And if you look in details of the pulse oximetry and the capnography, you can see that just before this patient desaturate, this patient, his breathing was interrupted, he stopped breathing, and then you have the desaturation here. So what happened in the brain? So when you look at the brain, you can see on the brain oximetry, there's also a reduction in the brain oximetry as you have a reduction in your pulse oximetry. And this is very useful because sometimes your pulse oximetry, particularly in very sick patients, sometimes is unreliable. You don't know, am I having a real systemic desaturation? When you have a real systemic desaturation, you'll have brain desaturation. If you don't have brain desaturation, that could indicate that maybe the pulse oximetry is not reliable, because sometimes in some patients you have vasoconstriction in those patients. But let's look in detail what happened to the component of brain oximetry. Well, what we can see in this patient is that the brain desaturation was mostly associated, again, with an increase in the deoxyhemoglobin as opposed to the change in oxyhemoglobin. Another example a patient who has cardiomyopathy, elderly patient that we have an induction, we intubate him. You can see there's a reduction in the arterial blood pressure, and then there's a raise in the blood pressure. You can appreciate the pulse oximetry went down significantly and came back. And again, you see in this patient reduction in brain oximetry, and then a rise in the brain oximetry signal. In this patient, when you analyze in detail, what you'll notice is that initially you'll have a rise and then a fall in the deoxyhemoglobin. And the oxyhemoglobin initially goes down, but then because you're rising his blood pressure and you're increasing his brain perfusion, then you have a second peak, which is explained by the rise in the oxyhemoglobin, which explains the rise in the brain oximetry afterwards. If you have a reduction in your cardiac output or reduction in your hemoglobin, you're bleeding, these patients will have brain and somatic desaturation, both. How to make the difference? I'll just show you an example. This is a patient that we're having aortic surgery, and we're having progressive hypothermia before a circulatory arrest. When you look at the oximetry, you see some mild change, initially, and then you see the significant reduction. This case was reported in the paper I mentioned before this was published. So when you look at in detail what happens, you notice that initially the hypothermia gradually was creating a reduction mostly of the oxyhemoglobin because the cardiac function and the blood pressure was gradually decreased. And then once with minimal change in the oxyhemoglobin, but once you had the circulatory arrest, then you can see the significant reduction in the oxyhemoglobin with a rise in the deoxyhemoglobin. A simple way to use this technology, and this can be done just with a linear probe, is to examine femoral vessels. And the femoral vessels is normally, as you can see in a patient with a normal cardiac output, normal venous return, it's a continuous wave, and it changes with respiration. In fact, the femoral vein does not transmit the pressure of the right heart because there's the pressure gradient. The pressure is normal on the right heart. So when you look at the CVP waveform, your CVP waveform is normal, and the femoral vein is continuous. If you develop somatic and cerebral desaturation, and it's from hemorrhage, you'll see desaturation. But a simple way to examine those patients is just look at your CVP. Often the CVP will be reduced. It will be flattened. But when you look at the femoral Doppler, what you notice in those patients is that you lose the signal during every breath. And this is just secondary to the inferior vena cava collapse that you see in those patients who are spontaneously breathing. On the other hand, if you have the same type of desaturation, cerebral and somatic, and it's a result of cardiac dysfunction, as you can see, well, you can look at your CVP waveform, the value will be elevated. But if it's significantly elevated, then what will happen is the pressure will be transmitted down to the femoral vein Doppler. And this is relatively specific of right heart dysfunction. So this could be represent a very interesting and simple way, and it's something known to radiologists for more than 20 years. But in order to examine and to differentiate the mechanism of brain and somatic desaturation. So as you know, these patients with COVID-19 can develop cardiac dysfunction, right heart dysfunction. And one of my colleagues who's in Basel, Dr. Caroline Gebhard, with a group of, with the Department of Angiology, decided just to see consecutive patients, what are the relative prevalence of abnormal femoral venous Doppler. And in fact, they observed that 4 out of 20 patients, COVID-19 patient, had significantly femoral pulsatility or even popliteal pulsatility, because when you're on a prone position, you can examine the femoral vein, but you can examine the popliteal vein. Out of these 4 patients, in fact, they were followed for a month and there were 3 deaths. The deaths were all on these 4 patients. As you know, right heart dysfunction is a bad prognosis. And this is just to show you one example. So this is the aspect of the femoral vein, which is pulsatile. It's almost biphasic. And when they did the measurement, this patient had high troponin, high BNP. And this was the detail of this patient who unfortunately did not survive. This patient had RV dysfunction and high systolic pulmonary artery pressure. So in summary, Brain monitoring using process EEG can detect under, or over sedation. It can detect seizures, and it can also detect burst suppression, and this can help you to adjust your sedation in your patient. Brain and somatic oximetry using both oxy and deoxyhemoglobin will help you to identify exactly where's the problem. So if you have, again, if you have a desaturation of your brain and a desaturation of your upper extremity, but it's normal in the lower extremity, this is quite typical of a superior vena cava syndrome. The mechanism of desaturation can be identified by looking at the components of the brain saturation. So if you have just hypoxemia, what you'll observe is mostly an increase in the deoxyhemoglobin with minimal change in oxyhemoglobin. If the problem is mostly reduction in your perfusion, you'll see a reduction in your oxyhemoglobin, which will be much more important than on the change in the deoxyhemoglobin. And in some patients, you can have a combination of those two. Finally, when you combine brain monitoring with whole body ultrasound, now you have the ability to much more precisely identify what is the mechanism of NIRS desaturation. Thank you for your attention.
Thank you, Andre. That was fantastic. Thanks very much. I don't know that we have any questions really, but maybe I suggest actually we're just about running out of time. Andre, would you like to maybe give us a take-home message, maybe about you know, the way you use EEG and O3? What would be the take-home message for us?
I think it's a nice combination because now we know from recent paper that if you have burst suppression, and that's been shown in cardiac surgical patient, elderly, was just published in anesthesiology recently, burst suppression is associated with delirium. On the other hand, is burst suppression the same if your brain saturation is normal and then secondary to too much anesthesia? Or is it the same if your burst suppression is associated with hypoperfused brain? So we don't know the answer for this. And I think upcoming studies will look at them. It's like if you're measuring, it's much better when you monitor your heart rate and your blood pressure than either one alone, because they will tell you how hemodynamically significant is tachycardia, for instance, or is it well tolerated? So I think the way we see simple brain monitoring, I think it's really the combination of these two monitor, which give us some insights. But again, I always mention that monitor comes from the Latin word monere, which means warning. And the monitor only tells you there's a problem. And what's very important is to bring whole body ultrasound in our practice in order to identify the mechanism of desaturation or the mechanism of burst suppression.
Thank you, Andre. I think for me, I find it very hard to explain really why the resistance to monitor the brain when we're not asking people to drill holes in heads or put some special scanners or put magical radioactive material. We're asking them to put a couple of stickers on the forehead that cost a few dollars, and the information you gain is so much more than not having those. Of course, it doesn't work in every patient. It doesn't work in every situation. But I can't understand why people don't want to know rather than know. You know, the presence of suppression, the presence of desaturation, all of those things are important. And the more and more we monitor, the more and more we will get to know about the brain. I don't know if we have any questions. I'll check the line again. I don't think we have. So I'm gonna thank you, Andre, once again. Thank the Critical Care Forum Canada, and thank Masimo for sponsoring and all the technical team who made this webinar possible. I hope to see you again soon. Thank you very much.